Thank you, Lori, for the introduction. Let's see, share desktop. PowerPoint, let's see if this works. Can you all see my screen?
Yes.
All right, well, thank you for that introduction. I also mentor and teach interested medical students at the University of Arizona College of Medicine in Phoenix. And in fact, I have some of them helping me with some research projects. So I'm enjoying being involved with the medical college as well. And I think everybody knows you. Lori is the president of Valley Sleep Center, but she's also a sleep educator, a sleep coach, and probably everything in between there, given your role. I'm sure you wear many hats. So, okay. So this is a standard disclaimer from Inspire. I'm not sure if this meeting is being recorded or not, but if it is, just be aware that it is, or just assume it is being recorded. And I'm assuming these instructions still apply. I got these from Inspire.
Yeah. Their questions are anonymous.
So you can ask questions, and then at the end we'll take questions. I have a fair number of slides, but a lot of them are kind of standard slides about Inspire, and I think that a lot of the value here will be really the question and answers. I did choose to cover Inspire just in case there are people attending that have not seen this presentation before, so that you know what we're talking about with Inspire. For those of you who have seen this presentation, this will be a little bit familiar, but we will discuss the two-incision approach and how it's different from the standard approach. Okay, so briefly we'll cover what obstructive sleep apnea is. There are some fundamental differences in our breathing when we go to sleep. One of them is posture, because we're lying down, and that gravity can actually cause tissues to fall backwards in the throat, not just the tongue, but the palate and the side walls of the throat. And we're unconscious, and so our neurological system, which normally maintains a little bit of contraction in the throat musculature when you're awake, relaxes, and with that relaxation, there's a greater potential for collapse, which is what happens. And if it's bad enough, it will actually block off airflow, and you have sleep apnea. Estimates, easily 20 million people have moderate to severe obstructive sleep apnea in the United States. Estimates about 8 to 10% of the adult population over 30 have some degree, I should say not some degree, have moderate to severe obstructive sleep apnea. If we include mild sleep apnea, it's actually about 25% of adults over 30 have at least mild sleep apnea. Here, just a little graph that shows what happens to oxygen levels during apneas, and these particular ones are very long, and you can see, these oxygen levels, which start at 97% in this case, fall down well below 90 and into the 80s, and in this longer apnea lasting almost a minute and a half, this person has oxygen saturation down in the 70s. We've all seen patients who get down into the 60s, which is actually pretty frightening, but it really does happen. There are tremendous consequences to untreated sleep apnea. I like to think of them as the consequences that the patient is aware of, and then there's the consequences that they may not be aware of, because it's internal damage which accrues with every night of untreated sleep apnea. The symptoms that a patient would experience, most people are familiar with fatigue, finding it hard to work and concentrate. People often refer to brain fog because they just can't really get their head clear. Of course, loud snoring, which it can be absolutely disruptive to sleeping partners, and a much higher risk of motor vehicle accidents because of falling asleep at the wheel or being inattentive. As a physician, I'm a little bit biased, and my greater concern is actually the silent damage which is accruing internally particularly to the cardiovascular system, but also to the brain, and the reduced life expectancy that produces in sleep apnea. Someone, for example, with severe untreated obstructive sleep apnea has about a 5-fold increased risk of dying of cardiovascular disease compared to someone who doesn't. And 5-fold is a 500% increase. And so that's not a trivial amount. That's an enormous increase in cardiovascular risk if it's not treated. So as many of you know who have used or are using CPAP, CPAP, which stands for continuous positive airway pressure, remains the frontline treatment for obstructive sleep apnea. And the reason for that is that nothing else compares in effectiveness. CPAP has about a 99% effectiveness if you are able and willing to wear it. There's nothing else that compares with that, including Inspire. It's also risk-free and relatively inexpensive. So you put all of those things together, and it's always, with a few exceptions, I should say, but it's almost always our starting point. However, if you can't get used to CPAP and you simply can't sleep with it, which is a large number of people, or you can sleep with it, but the wearing of the CPAP and air leakage and mask slippage and noise ends up waking you up frequently during the night, then that degree of disruption to your sleep can be enough that you may want to consider other treatments. Next, in the non-invasive treatment of obstructive sleep apnea, we have something we call oral appliances, and there's a number of them out there. Last time I spoke with a sleep dentist, she told me there's more than 100 oral appliances that are FDA approved in the US to treat sleep apnea. And these are basically custom-made mouthpieces. There's just an example on the right, which pull the lower jaw forward and slightly out of position during the night. And what that does is, you can see in this model here, the lower jaw is forward probably a 1/4 of an inch or so. And what that does is open the space in the back of the throat, because the tongue is attached to the mandible, which is the lower jaw. And so as the jaw moves forward, it actually pulls the tongue forward, and that forward movement opens the space in the back of the throat. This can be effective, although nowhere near CPAP. Overall, this is about a 50% likelihood of success. But the challenges with the oral appliance is that it tends to work best for a mild sleep apnea, which is not our target population when we're talking about Inspire, which is for moderate to severe. And it's not tolerable to a lot of people because of discomfort. But it's always a reasonable option if someone wants to try this before considering any form of invasive therapy. Then we have, and I've titled it anatomy altering surgery. And that just means we're changing the anatomy of the throat in some way. Most of the time that involves removing extra tissue, such as the tonsils, portions of the soft palate, sometimes the portions of the base of the tongue, or repositioning one or both jaws. I'm not going to go into these surgeries a lot tonight because that's not our subject. These are very, very painful procedures, and they're permanent procedures. If somebody is a really good candidate for one of these procedures, it is still worth considering because it's a one and done sort of thing. If you're fixed by surgery, then you don't need therapy for your sleep apnea again. Unfortunately, most people really are not a good candidate for one of these procedures. So I'm very selective in recommending these surgeries for anybody. So this moves us to Inspire. Inspire was approved by the FDA in 2014. So it's been on the market in the United States outside of clinical trials for about 7 years. And it's essentially a completely implanted system that works during sleep by stimulating the tongue to move forward with each breath. When you breathe in, that's called inspiration. And so with each inspiration, a stimulus goes from the Inspire device to the nerve that moves the tongue, not to the tongue directly, but actually to the nerve. And the nerve tells the tongue to move forward. So it's not like feeling a shock in your tongue because the tongue itself is not receiving any electrical current. It's simply being told by a nerve called the hypoglossal nerve to move forward with each breath. And then it relaxes during exhalation when you breathe out. You turn it on at night with a small remote control that you can see in the picture. And then in the morning, you turn it off the same way. There are three parts to the system. There's what we call the impulse generator, pictured on the right side of the screen, and that's implanted in the right upper chest. Then there's a stimulating electrode, which is essentially a little wire that goes to the nerve called the hypoglossal nerve, and that's accessed through an incision just below the jaw on the right side. And then the third component is a pressure sensor, which is actually placed in a layer of muscle between two adjacent ribs so that the system can detect when you're taking a breath in. And that's how the system knows how to synchronize the impulse with your breathing. So when inspiration is detected, then the electrical impulse is sent to the hypoglossal nerve, causing the tongue to move forward. And this prevents the throat from obstructing. One of the common questions that I get is, how does it know when I have apnea so it knows when to send the signal? And the answer is, it doesn't. We're not actually waiting for the apnea. That would be counterproductive because then you'd still have sleep apnea. This is actually preventing the apnea from ever occurring. And I don't know if this, whoa, let's see if this is working. He's just going to turn on his remote like this. And I'm going to just skip this because we're talking about it anyway. Okay, next slide. This I find actually a much more interesting slide. I actually show this when I give this talk to groups of physicians because it's a really dramatic and real demonstration of what Inspire does in an actual person. Where's my cursor here? These two sets of pictures, one on the left and one on the right, are without Inspire and with Inspire. This is a schematic of the tongue obstructing the back of the throat in a model with sleep apnea, and with Inspire, how you can see this airspace now is open in the back. So here we have two views, one behind the tongue, which we call base of tongue, and a second view behind the palate, which would be up over here. So I'm going to play these. You can see right here, the airspace, which is where my cursor is completely obstructed intermittently by the tongue base and this thing here called the epiglottis. Here at the level of the soft palate, the airspace would be right here. There's no space there. And you can see this is like saliva and secretions. There's no bubbles, there's no airflow at all in this picture. Now the Inspire is turned on. So this is again at the level of the tongue base and epiglottis, just like you saw on the left over here. And there's Inspire, on, off, on. And you can see how the airway just opens up. And those are actually the vocal cords down below. And then here at the level of the soft palate, it's the same phenomena. Palate moves forward. You can see all the way down into the airway below. So it's really maintaining the airspace with inspirations. All right. So you saw this a little bit in that video with that person. Traditionally, this procedure is done through three small incisions. One below the chin, one in the upper chest below the collarbone, and then a third incision in the right flank. We're going to talk about the modification tonight, or we're doing this through two incisions. But regardless, with Inspire, it's a fairly quick recovery, 1 to 2 weeks. And in most of my patients, we're able to treat pain without the use of narcotics. Narcotics are the medicines that are like codeine or oxycodone. And people are returning to normal non-strenuous activities within a few days, and all physical restrictions are lifted at 2 weeks. The battery for the Inspire system, which is located here in the impulse generator, is going to last about 10 or 11 years. 10 to 12 is what Inspire says before requiring replacement. MRIs, just like pacemakers, there are some restrictions on MRIs, and they can be safely performed for the head, the neck, and the arms and legs, but no MRIs from basically the collarbones to the pelvis. In the midsection of the body, you cannot have an MRI. So the two-incision approach, this is the interesting part. I was fortunate enough to work with 3 other academic physicians around the country. Dr. David Kent at Vanderbilt University, Dr. Eugene Cho at Ohio State University, and Dr. Mark Wiedenbecker at Case Western Reserve University, all working together, came up with this a standardized way to do this procedure through 2 incisions. I will credit Dr. Wiedenbecker at Case Western Reserve for being the first to perform the procedure through 2 incisions. And then the other 3 of us, Dr. Kent, Dr. Cho, and myself, all started doing it through 2 incisions around the same time, about 14 months ago, or 13 months ago. We worked together to basically come up with the details of how to do it this way. We were very concerned about safety and making sure that we weren't giving up a good thing for something that was less good. And so we had a series of meetings and talking about anatomy and standardized the approach that we're all using. And then we published the technique in one of our journals. It happens to be called Techniques in Otolaryngology, Head and Neck Surgery, where a lot of new techniques are described. So this is going to be a very, very big buzz in my field over the next year. And as Lori said at the beginning, the FDA literally approved training other surgeons using this new technique yesterday. So Inspire, which was barred from training other surgeons to perform the procedure through 2 incisions, is now released to begin the process of essentially retraining physicians who are already performing the procedure through 3 incisions and how to do it with 2. And I will most likely be helping train some of those surgeons as well. We are, with my colleagues, we're in the process of collecting data on patients who are undergoing the surgery with 2 incisions. If there's anybody on this call who has gotten the procedure through me, it's always something I ask my patients is if they're willing to allow us to use their experience and their data as part of the ongoing research so that we can continue to improve the process. I've now implanted about 85 patients using the new 2-incision approach, which puts me right up there with Dr. Cho as one of the most experienced in the country doing it this way. Right now, I'm the only surgeon in Arizona doing it this way, but of course, that's going to begin to change as we start training other surgeons. What are the advantages of doing this? Why is it worth going through all this effort? Well, very simply, there's one less scar. And so it does eliminate the 3rd incision or the 3rd scar, which is made on the side of the chest. And what we're doing is essentially placing the pressure sensor, which would normally be placed through that 3rd incision between 2 different ribs, going through the same incision that we were making anyway to place the impulse generator. We actually tunnel through the muscle on the front of the chest called the pectoralis major to get down to the rib cage in that area, and then we place the pressure sensor there. It does reduce the operative time because of the one less incision to open and close, and on average, we're thinking about 20% shorter. My average surgery time from incision to putting on a bandage is about an hour, maybe an hour and 2 minutes, something like that. There's less pain post-operatively because of that no more flank incision. And a lot of people were a bit sore on the side, and so they couldn't really sleep on that right side for a while, where there's now no difficulty sleeping on the right side at all. And there's no more post-operative restrictions that we used to put in place. People previously were instructed not to raise their right arm over their head for 2 weeks, as well as they were instructed to rest their right arm in a soft sling for 4 days. So those restrictions have been abandoned. This next part is actually, it takes place at Valley Sleep rather than in my office. This is where when you get Inspire, they turn on the system for the first time about a month after the initial procedure. And at that visit, the team there will establish the initial settings, finding out what's comfortable for you as well as what seems to be effective. and programming that remote that you saw in the picture so that the Inspire device is set at levels that are appropriate for you. There's a series of levels from 1 to 10 on the remote, but one patient's level 1 is not the same as another person's level 1. So they have to figure out what those levels are going to be, and then you go home and begin using it that night. So the first month after surgery, you're not using the Inspire system. It's turned on a month later by the people at Valley Sleep. And of course, they teach you how to use it. This is a data. This doesn't happen to be my data, but I'll tell you in a second what my data looks like. This is national data. Before Inspire, the 29.3 that you see is the number of times per hour that the average person getting Inspire obstructs their airway without therapy. And you can see after Inspire, it's 6.2. It's about an 80% reduction in overall apnea with Inspire. And 6.2, in case you don't know, is almost normal. Anything under 5 is actually considered normal. So getting someone who's at 29.3 down to 6.2 is actually a huge victory. And this residual degree of sleep apnea is not threatening to the person. I don't think I have my data on this in this talk. My average actually pre-op AHI is over 34, and my average post-op is 6.7. So very similar, starting off a little bit more severe, closer to this top line here, but getting down into that 6 range. About 50% of my patients end up with an AHI under 5, so in that normal range. So I'm not sure where the 2/3 came. I didn't make this slide. I don't think that's correct. Snoring, which is really not why we're doing this procedure, is also dramatically better. But it's really not our primary measure of success. It's great if we can eliminate snoring. We're really interested in the apnea, but you can see there's a tremendous improvement in snoring with the majority of patients no longer snoring or snoring very, very minimally with Inspire. Satisfaction, which is good to know. You know, it's nice to quote statistics, but this is actual data from patients who have received Inspire. You know, are you satisfied? Are you not satisfied, or neither? And you can see 94% would categorize themselves as satisfied with therapy. And here's adherence to therapy long term. You can see that the average person is still using it almost in this particular study, almost 6 hours per night. I've seen other studies actually showing higher compliance. This is a really important number because studies show that if a device is used for less than 4 hours per night, whether that's CPAP or Inspire, then even when it's being used, it's not conferring enough benefit to the person to protect them against the cardiovascular and neurological complications. So 4 hours per night is considered a critical cutoff. And with Inspire, other studies actually show averages of about 7 hours per night with Inspire. Lots and lots of published papers in high quality peer-reviewed publications. I think now it's well over 200 that have been published. And we're also collecting long-term data on patients who've received Inspire now more than 6 years ago as an ongoing effort. I am one of the surgeons in sleep centers that participate in this, what's called a registry, which is essentially a way to collect anonymous data on patients receiving this. And I think it's over 6,000 now that are in this registry. So I do ask all of my patients to participate so that we can, again, gain from their experience. Most insurers cover Inspire now. There's only 1 or 2 payers in Arizona which don't, but all of the major ones do, and Medicare does cover it as well. The VA also covers it, although it's not easy to work through the VA, but we can get that done. So who is this for? It's not for mild sleep apnea. This is for moderate to severe obstructive sleep apnea in someone who is not getting real benefit from CPAP, either because they're not wearing it, which is a very clear example, or they are wearing it, but they're not wearing it for more than 4 hours a night, or their sleep is so disrupted by CPAP therapy that they're really miserable with their CPAP. You can be overweight and get Inspire, so this isn't just for skinny people, but you can't be beyond a certain weight limit. There are weight limits currently for most commercial insurance companies. There's a limit of a BMI, and if you're familiar with that, of 32, and a cap at 35 for all insurance, including Medicare. Next, you have to pass what's written here is an airway anatomy exam. We call it sleep endoscopy. And what this means is that once we decide that the person is a candidate for Inspire, they meet all of the criteria, I've met them in the office, we actually have to take them to the operating room for a sleep exam. We give them intravenous medicine just to fall asleep. We don't put a breathing tube in. And I literally look around inside their throat using a small flexible camera to evaluate exactly how the airway is obstructing during sleep. There are multiple sites where the airway can obstruct and different ways that those sites can obstruct. Most cases of obstruction will benefit from Inspire, but there is one pattern of obstruction where the two sides of the throat collapse and come together at the highest point in the throat, which is right at the level of the soft palate, that would not likely benefit from Inspire. And we don't want to implant it in those situations. So if somebody has that pattern, then they're not a candidate. Currently, in my experience, it's about 15% of patients will go to sleep endoscopy and have the wrong pattern of collapse and not be Inspire candidates. And you have to be 18 or older. If you go to inspiresleep.com, you can see a lot of information about benefits and safety information, as well as information about their patient ambassador program, which I think Lori is going to speak about. So I'm going to let Lori talk here, and I'm going to unshare my screen here.
All right. So if any of you are interested in pursuing a consult to see if you are a candidate for Inspire, you can call 480-830-3900. If you're in the webinar, you can also chat your phone number. I'm the only one that's going to see it. And we'll make sure that you get an appointment. I think we can open up to questions. Oh, ambassador. So I'm actually the patient ambassador on this call. There's lots of other people, but I watched a lot of our patients' lives be changed by using Inspire. And I struggled for years with severe obstructive sleep apnea. And I spoke to Dr. Weiner at a dinner. I've been watching it for 5 years. And he said, I think that I can help you. And so I was able to get implanted over a year ago, activated just about a year ago. And I now have the device, and it has changed my life as well.